Hello.
Hello, Hitesh.
Hello.
Hello.
Can you hear me? Hello.
Yes, Hitesh, carry on.
Yes, we can hear you.
For very best. This is inferior turbinate, very hypertrophied. Pus is trickling down there from sphenopalatine area. This is extensive polyposis.
Hitesh,
Yes, sir.
how will you prepare the patient for the surgery in your clinic, no?
Sir, before 10 days, antibiotic, steroid, decongestion drops before 10 days. Then after 10 days, I will always do CT scan. Okay. After medicine, I will do CT scan.
Uh,
This is middle turbinate.
do you suggest allergic test preoperatively?
Hello.
Do you suggest allergic test preoperatively?
Sir, yes, we can do pre-operatively also, or we can do post-operatively also, sir. Allergic skin prick test. And pre-operatively also immunoglobulin E, IgE, sir. This is middle turbinate. This is extensive polyp. No unseen is visualized here.
Preoperatively.
So first step is to debulk the polyp, to delineate the anatomy. Okay.
Hello, Hitesh
I'm
bhai.
waiting for debrider here.
Hello. Hello, Hitesh bhai.
Yes, ma'am. Yes, ma'am.
Which form of steroid preoperatively you prefer? I mean, oral steroid or topical steroid?
No, oral steroid, ma'am. Oral steroid for preparation of patient, oral steroid.
Okay, before surgery, oral steroid.
Omnacotil 20 milligram for 1 week.
Okay. Do you prefer topical steroid before surgery?
No, ma'am. Because topical steroid never penetrate in such huge polyp. Okay. So no use of topical steroid before surgery, ma'am. Because topical steroid anyway no penetrate any inside the sinus. Okay. So we have to use oral steroid only before surgery.
Okay.
I am waiting for debrider. Oh.
Yes.
Okay. So first step in this surgery is to debulk the polyp.
And there is
To delineate the anatomy.
septum. Hello.
Yes, ma'am.
Deviated septum with inferior nasal spur, same side. So
Yes, sir. Yes,
would you
yes,
like to correct this?
Maybe at last, ma'am. Maybe at last, because right now it is not obstructing my view. Okay. So maybe at last I will correct. Okay, if required. Right now, not. Foot switch. Irrigation બધું ready છે આમાં.
And can you show the picture of opposite nasal cavity?
So first step is to debulk the polyp. Okay.
Okay.
And how to use the debrider? See, don't touch the debrider blade over the septum. Okay. Always use debrider under the vision. Okay.
Yes.
The first step is to debulk the polyp, to delineate the anatomy.
Yes.
I am using 4K camera first time. Thanks to Nina ma'am, Hardik sir and Devang sir for such a nice arrangement. 4K camera with 60-inch monitor here in OT.
Oh, wow.
It's really nice.
Yes.
In OT here is 60-inch monitor. Okay. And always irrigate while using debrider. Okay. To clean the blood.
Hitesh bhai, Manoj here.
Yes, sir.
Normal
Yes, sir.
saline છે કે warm saline?
No. Routine saline, sir. Routine saline, normal saline. No warm saline. Bleeding will be there. I am prepared for that. Okay, because of extensive polyposis, bleeding will be there.
Oh, lot of
See,
work.
pus is also coming out. I am just debulking. Okay.
Okay.
Percept straight neck, not to ready rack. Narrow seal, suction, narrow seal, straight forceps. Please be ready with straight forceps. Uncinate was there.
What is
I already debrided the few
yes?
uncinate.
What
Okay.
is like in what is the blood pressure? There is lot of oozing. So
Uh,
what is the BP?
100, 106 by 69. Pulse is 80. Okay. Please, if I request anesthetic to
Usually we
keep the
prefer
pulse
yes
at
hypotensive
60.
anesthesia. Yes.
Yeah, yeah. And pulse at 60. Okay. I request anesthetic to keep the pulse at 60 because this is extensive disease, so bleeding will occur. Okay.
To
If bleeding
keep
is
the
there,
pulse,
take
Hitesh
medicine
bhai.
for a few minutes. Don't be in hurry. Okay. Most of the chance of complication are because of bleeding only. Okay. So don't be in hurry. You have to make patience. Wash. Debrider. 45. First I debulk that polyp. Okay. This is part of the uncinate. Packing. Straight for seven. Bleeding will be there because of extensive polyp. Okay. Cord suction. Adrenal medicine. हाँ. Yes, yes. Straight. पहला straight debrider दें. Cord उनका ऊपर. I am right now doing debulking only. Okay.
Hitesh bhai,
Yes, sir. Yes, sir.
which number blade are you using? 12 or 0?
No. Right now red 40, sir.
40. Okay.
This is red 40,
Any
sir.
criteria to use a particular blade and particular sinuses?
Sir, for debulking, I use 0 degree. Then over the nooks and corner, like here, I use 40 degree. And after I opening the maxillary sinus, I widen the sinus with 40 degree only, sir.
Okay. And for
Inside
frontal?
the sinus, we can use 40, 60, 120 degree inside the maxillary sinus. See,
Okay.
uncinectomy I had done only with debrider. Okay. This is the area of the maxillary sinus. Okay. For seeking the maxillary sinus, for entry, we have to push the suction laterally and inferiorly like this. Okay. For junior particularly. See. Laterally and inferiorly. If you hit like this, you may injure the inferior wall of the orbit. Okay. So this is the movement. Okay.
Okay.
In the
This is
second
I am inside
OT,
now. I am
we
inside the
also have a
maxillary sinus.
septicoplasty
So
plan.
now I wide this with 40 degree. Okay, bleeding is there, but no worry about bleeding. I am prepared for bleeding since yesterday after watching the patient and scan. Okay, it
Okay.
because of extensive disease and
The OT2 is getting
Okay, lagay
limited
Sunil,
infiltration
40
of
lagay
case of
video
deviated
full word
septal
letter.
to left and
I have to use
Chaitri
Merosil in between. Okay,
Chaitri
Your
shy
voice is not clear. Simple.
ma'am, your voice is not clear.
Hitesh sir, we are shifting to Dr. Chaitri right now. She is in
बेटा
OT2
nasal dressing
and
Okay, okay,
starting
okay, ma'am.
septoplasty.
आ रहा है ब्रदर nasal dressing आपको
Dr. Chaitri? Hello?
yes hello can you hear us
Yes. Just give us an idea what the case is and
Yeah.
what is the nasal endoscopy findings.
the patient is a 22-year-old male having a complaint of long-term left side nasal blockage. The patient has DNS to left. I've infiltrated on the left side of the nasal septum, and this is the right side of the nasal septum. And we are still to infiltrate on this side.
Any special method how you infiltrate? Any spinal needle or just
No, we use a normal 26 gauge 1.5 inch needle, and the patient is young, so we use the prepared xylocaine with adrenaline solution.
okay.
How will you decongest the nose before taking patient in the surgery? Hello, Dr.
Sir,
Chaitri.
sir, we've put a topical nasal patty before starting the surgery 2 hours before taking the patient. We put a solution of xylocaine, xylomist, and xylocaine with adrenaline.
Okay.
So we've
And you would like to
decongested
keep
the
it for how much time? 15 minutes, 10 minutes, or more than that?
Yes, sir. We generally do it when we start the OT. Right now, we've done it in the morning, and we kept the nasal patty. It is just for the topical decongestion.
Okay.
મને આપો બીજું.
How the decongestant will helpful to you in during surgery?
So the edematous mucosa, the inflammation, and as we are using the xylometazolin, it will also help in the decongestion of the nasal mucosa.
Okay, so he will give the cavity space to do a
Yes,
surgery.
yes.
Every septoplasty, would you like to go for the CT scan?
Yes, sir. As we generally get the CT scan done in all the patients of septoplasty. But sir, we also have advantage of being in an institute. So
Okay.
we usually
we
get
are
CT scan
seeing-
done in all
Can
the
we
patients.
shift to OT1 to see Dr. Hitesh surgery? And we right now have the third surgery also on.
अरे फेदरा बराबर भराओ ने यार.
Hitesh bhai,
Hitesh? Hello.
Yes, ma'am.
Why don't you go other
Yes.
side and just wait for the hemostasis to come on right side and then operate again?
I am just removing. Hello.
Yes.
packing process. Recording is
Clearing the maxillary sinus, no?
Yes, sir. I am just clearing the maxillary sinus with 60-degree blade and 0-degree endoscope.
0-degree endoscope.
Yes.
Hijung pata word back la. Betadine no so what?
Wash. Nerosil. Here is the polypoidal tissue. Wash. Keep irrigating in between, okay? So that field remains clear in spite of such type of bleeding. Keep irrigating, keep irrigating. So you need not to remove the scope in between
Hitesh,
repeatedly.
why don't
Okay.
you enlarge the ostium posteriorly more so that you will have a rich lateral?
Yes, sir. Pardon, sir.
Why don't you open them posteriorly, no? Posterior fontanelle.
Sir, in case of huge fungal sinusitis, I only do huge mega enterostomy. Otherwise, it's okay for me, sir.
Okay.
No mega enterostomy in such type of
What are the
disease, sir.
disadvantages of mega
Only mega enterostomy in case of fungal sinusitis, sir.
No. What are the disadvantages and advantages of the big mega enterostomy, middle meatal enterostomy?
Sir, in case of mega enterostomy, sometimes patient feel the pain while breathing because of excessive air.
Yes.
Okay. So no need mega enterostomy in this patient, I think.
Sometimes patient complains of mucus plugging, mucus coming out in the throat and always complaining something coming in the postnasal space. Have you ever seen this in patient of mega enterostomy in follow-up?
What, sir? What?
Lot of mucus coming in the postnasal space, no? Postnasal drip.
Yes. That is the problem with mega enterostomy.
What do you mean by adequate enterostomy and mega enterostomy?
Sir, adequate means, sir, I usually widen, sir, superiorly up to the inferior wall of orbit, inferiorly up to the inferior turbinate, anteriorly up to the nasolacrimal duct, okay, and posteriorly I widen only 5 to 10 millimeter. I not widen up to the posterior wall of the maxillary sinus like up to this area, okay.
Yes.
This is type 1, sir. Okay, type 2 is what? Type 2 means you have to widen this area up to the posterior wall. Then this is type 2. Type 3 means you have to remove this wall or this wall of the inferior, this wall with inferior turbinate. Okay, this is type 2. And type 4 is our routine medial maxillectomy is type 4.
Yes.
Okay, type 3 and type 4 usually use in case of approach to the tumor. Okay, and a mega enterostomy type 2 is for fungal, and this is for this such type of disease only type 1. Okay.
Okay.
Now I will examine the maxillary sinus with 70-degree. How to use 70-degree? See, first face the 70-degree superiorly. Okay. Then enter, and while you reaching the middle turbinate, turn it laterally, okay. For juniors, turn it laterally, okay, like this. All these are edematous mucosa. Wash, fast wash, full wash, okay, good.
Lot of mucopus there
Wash.
inside, no? And the roof in posterior inferior part.
Yes, sir. I will give wash there also, sir. Wash. Ready with wash. Wash. I'll wash the maxillary sinus to clear that pus. Still there is a pus, okay. Use merosil, big merosil, please. I will insert big merosil half of the piece, okay, inside the maxillary sinus and mop the maxillary sinus to clear that pus. This is half piece of maxillary sinus. Oh, sorry, half piece of merosil. Suction, out suction. Out suction. Thank you. Then I push the merosil inside the maxillary sinus to mop the maxillary sinus. This is half piece, okay, big merosil. You have to take a big merosil. Wash, please wash. Okay, see, pus is coming out, see. Wash, please continue, wash. See, pus is coming out, see. Here is a very good role of merosil, see, mopping. mopping the sinus with Merosil. Edematous mucosa also a little bit settled down after I remove this Merosil. You can see the change. Okay. Yes, see. This is the best way to remove the pus and anything from laterally. Okay. Because all edematous mucosa need not to be removed. It will settle down post-operatively after medical treatment. So don't remove unnecessarily all the mucosa. Okay. See, pus is still coming out. Upward forceps. Give me upward forceps. Thank you. Big upward forceps, Sunil. Now I removed Merosil and see inside. Wash please. Wash please. Yeah, 120 degrees. Then. See now no pus. So here is the very good role of Merosil. Okay.
Very good.
And all these are edematous mucosa superiorly. Need not to remove
Can't see
all every
entero
time.
wall, no? In 70-degree, one can see
What, sir?
the wall also. Enterolateral wall.
Wait, sir. I will show you.
So in the third small PIP,
60
we
then.
have the third case of extensive polyposis. It is done by Dr. Sorin Shah. And because we also have another extensive polyposis, only PIP 1 audio is
Oh.
presented.
Sorry, is doing, no? Third one. PIP.
Wash.
Any questions for septal surgery?
This is 120-degree blade. Okay. We can reach the corner of the maxillary sinus laterally with this blade.
Lateral angle. Good, very good.
I am using 120-degree blade. Okay. Suction. 60-degree blade. હજી કાઢવા પડશે બોલો તો 60-degree blade. Still polyp are there in anterior wall. Okay. If I couldn't reach there, then I will do a CFT at end. Okay. Let us see if I can remove. This is 60-degree blade. Okay. Bleeding is inevitable because of extensive polyp extensive disease. You have to work with bleeding. Okay.
Going on.
અને પેલું છે ને પિત્તળનું section.
Hitesh sir?
Hitesh? Hello.
Yes, sir.
It's very good clearance, Hitesh.
Yes, sir.
Preserving the submucosa.
Yes, sir.
Yeah, very good preservation of the mucosa. And just now you are removing the disease from the anterolateral wall, no?
Sir, I can't hear you. Hello.
Just now you are
Hello.
clearing the disease from the anterolateral wall.
Yes, yes, sir. I had already clear anterolateral wall, sir. Little bit edematous issue are there, sir. And another useful instrument is this copper suction, malleable. Okay, very useful in maxillary sinus for juniors. See, I can reach anywhere with this suction. Okay. Sometimes 120-degree with debrider blade not reach at that area. This suction is reached. See, I have to open all this edematous mucosa because pus is behind this edematous mucosa. Okay, with suction. Wash please. (120-degree blade, please. (120-degree blade and copper suction is very useful. Malleable copper suction inside the maxillary sinus at most lateral area.
Hitesh sir, I have a question. What
Yes.
instruments you use for the anterior wall? Like you use a curate at times, or sometimes you need a more anterior 120-degree
For
force.
anterior wall, ma'am. For anterior wall?
Yes, for anterior wall, sir.
For anterior wall of maxillary sinus, you mean?
Yes, for maxillary sinus.
I can't hear you properly. Hello.
Sir, for anterior wall of maxillary sinus, what other instruments do you use other than the debrider?
Ma'am, I already told. See, a 120-degree blade, you can use a malleable copper suction, and if you can't reach, then you have to go for CFT. Okay, CFT is the only answer. Otherwise, wash.
Hitesh,
Yes, yes, sir.
hello.
Yes, sir. Yes, sir.
Hitesh, there is a basic principle of Fess that once you have opened up the sinuses, the ventilation and drainage is maintained, the cobblestone
Yes, yes, sir.
of the maxillary sinus gets
Yes, yes, sir.
come
Yes, sir.
back to normal.
Sir, I am not removing. Sir, I am not removing all mucosa. I am
Okay.
removing it because of a pus. Pus is inside,
Pus
sir. In the
underlying.
crevices of
Okay.
mucosa, pus is there. Okay,
Okay,
that's why I remove this. Trying to remove the open this. Okay, otherwise that I know this mucosa is, this mucosa is not need to remove this edematous mucosa, but
No.
in the crevices there pus. That's why I open it. Okay.
Oh no,
I am
we
trying
agree
to
with
open this.
whatever you are doing. This is just for the junior colleagues. I am telling the principle.
Okay, 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 okay. Sir.
They don't have to remove all the mucosa of maxillary sinus.
I will take little time, okay,
Mucosa
to remove
needs to
all
be
this.
added. You are doing excellent, John. No query about that.
120 degrees.
Chaitri,
Yes, yes, sir.
OT1 માં shift કરાવો ને થોડું. Second OT માં shift કરાવો ને.
Okay. 60 degrees.
કહું એ જ પૂછું. For junior.
Already use 120 degree whenever 120 degree reached. Okay.
Hello.
I try as much as possible to avoid CFT. Okay.
Chaitri, can you hear us? Chaitri? કર્યું ભાઈ?
I think enough work in maxillary sinus. You all agree?
Yeah. More than enough.
Okay. Thank you. Now we will proceed for frontal sinus. Okay. Intake Bula technique. Okay.
Hitesh,
Yes, sir. 45.
from somewhere we got a question. Is this Dr. Satish Jain doing or someone else?
What, sir? What?
Some was asking, is this Satish Jain doing or our local?
No, sir. I am only 0.00001 of boss. Now we will proceed for frontal sinus. For frontal sinus, for reaching the frontal recess area, first we have to debride this polyp, okay, and make a space there and identify the limits of frontal sinus, frontal
Yes.
recess.
Hitesh,
Yes, sir.
here you are doing intact bulla technique for opening frontal sinus, right?
Yes, yes, sir. Yes, sir.
Yeah. Tell the
I am
audience
always,
that.
I am always
You are
doing
keeping
intact
the
bulla
bulla
technique for
intact.
frontal sinus. Yes, yes, sir.
Okay.
First, I will make a space here, okay. And while debriding this area, remember, work in the middle part, okay. Don't work too laterally, don't work too medially, don't work too laterally, okay.
Any advantage of doing this intact bulla technique apart from
Sir, to preserve the trauma to prevent trauma to the anti-ethmoidal artery, okay. In
Okay.
most of the cases, almost in 95%, anti-ethmoidal artery is behind the bulla, okay.
Okay, yes.
It is little bit difficult technique, but after you become used to with this, we can do it easily, okay.
But watching your surgery, it seems very easy.
What, sir?
Looking to you doing surgery for intact bulla, it seems very easy. It's not difficult.
Yes, sir. For seeking the frontal sinus, frontal recess, you have direction. What is the direction of instrument? See, direction of instrument is from medial to lateral, okay.
Yes.
While you seeking the frontal sinus, your direction is medial to lateral, okay. Always direction is medial to lateral, okay.
Which instruments you are using, Hitesh? Crowd suction?
What, sir?
Which instruments you are using to open the frontal
No, this is suction, sir. This is suction only.
This
This is
suction.
crowd suction.
Crowd suction.
For seeking the maxillary sinus, always use thick suction. For seeking the frontal sinus, use thin suction. Okay, yes.
Thin crowd.
You all must have seen the CT scan of this patient. Frontal sinus is very difficult in this patient. Let me see how I can proceed. Okay. First, clear the axilla. Okay. Merosil. Upward forceps, merosil. You have to keep merosil for a while to stop the bleeding and then again examine. Okay. Don't be hurry. Okay. In case of bleeding, don't be hurry. And you can push the merosil gently, okay, to break the septas. But gently, huh? We can push merosil, but gently. In this case, cribriform is Kiros 1 or 2, okay, as per CT scan. Suction. $60 blade. Upward. Yes, sir. I am
red
just
60-degree blade in frontal sinus once you identify the landmarks.
sir, wait, sir. I am just debulking the polyp inside the frontal recess. Okay.
Yes.
With 60-degree blade, and then I will show you. The as per CT scan. I will show you the supra-orbital cell and frontal sinus both. Use suprabular cell and use frontal sinus in this patient.
Yes.
Yes, sir.
Then any trick to identify whether you are approaching the frontal sinus proper or the suprabular recess?
Yes, sir. I will show the landmark, sir. Yes, sir. Wait, sir. I will show the landmark.
Right.
3 landmarks are there, sir. One is the beak, okay, in the center.
Frontal
Laterally is the lamina, and medially is the lateral surface of the middle turbinate. We have to stay in between, okay.
of middle turbinate, yes.
Wash. You have to stay in between, okay? Whenever you are doing work with debrider, don't work laterally, don't work medially, okay? Stay in between. Suction. See, this is huge frontal sinus, okay? Polyps are there. બસ 2 મિનિટ વોશ નહીં આપતા 2 મિનિટ વોશ નહીં આપતા નીચે પાણી ભરેલું રહ્યું છે ને in frontal use less wash, okay, for practical points, okay. Otherwise we are always doing suction there and saline will collect here and fog the endoscope. Less use wash while doing work with 70 degree, okay. Now I will remove this mucosa, okay, inside the frontal sinus and delineate the supraorbital recess and frontal sinus clearly.
Hitesh,
Yes, sir.
there is a dictum, like if you want to open the frontal sinus, then open it full-heartedly. Otherwise, if you don't open the properly, then you are bound to give iatrogenic frontal sinus.
Iatrogenic. Yes, true, sir. You have to keep all the limits open, okay.
Yes, sir.
Yes. True, sir, true.
We can see very nice inside.
Yes. Sir.
However, there is some oozing.
आँख ने पूछ सकते.
Yes, what is the pulse rate of this patient?
What, sir?
Pulse rate of this patient?
Right now, 70, sir, 70. But in spite of this, sir, bleeding is there. Very nice anesthesia given by anesthetic, but because of disease, bleedings are there, sir.
Yeah. But can you ask anesthetists to do little more, near 60 or so? That may help you little bit.
Yes, sir, they will do it.
You can always ask, na? It is our right to ask. $120 ready રાખજે. You can do little bit work blindly also inside the frontal sinus if sinus wall is intact. Not push the debrider, okay. Sometimes we have to do blind work inside the sinus by our tactile sensation, okay. See, this was the, I think, type 4 cell was there, okay. In CT scan, see, I had already broken with debrider this cell, okay. This was the type 4 cell, okay. But now it's very difficult to remove that bone. Let me try. Scoop. Frontal scoop. Frontal ball point. Let me try if I can reach with scoop or not. Bleeding is also there. Yes. This was type 4 frontal cell as per CT scan. Okay. Ball point, scoop, frontal nu be ready જ રાખજો. This was the cell. It is difficult, really difficult to remove that bone. Let me try. It takes time, huh? Yes, sir. Meanwhile, you are doing removal of this type 4 frontal cell.
Okay.
For the sake of knowledge of audience, can you tell what is type 1, type 2, type 3 and type 4 frontal?
Yes, sir.
This is for the young colleagues and the more of theoretical value, but you should be knowing when you are doing frontal.
Yes, sir. Sir, type 1 cell is one cell above the agar-nazi cell. Okay, that is the type 1 cell.
Type 1
okay.
frontal. Yes, sir.
Type 2 is 2 or 3 cells above the agar-nazi is type 2.
Yes.
Type 3 is cell extending inside the frontal sinus. That is type 3. And type 4 is totally cell inside the frontal sinus.
Okay.
Yeah, totally inside, like this cell. Okay. This was the type 4 frontal cell.
Right. Yeah, I had broken, but really difficult to remove that bone. Let me try. It takes time. If I can remove, it is really difficult. I tried curate also. Now I am trying with frontal ball probe. If I can negotiate behind section. For juniors, always don't put scope like this. Okay, no camera like tilt. Okay, always camera in real position. Okay, otherwise it misguide anatomy landmarks, and you may injure the surrounding structure. Let me try with ball point again. If I can remove. My both assistant are very nice, really. They keep ready everything. Okay, really nice. One is my staff and one is doctor from here. What is your name? Dr. Saili is here, and one is my staff Sunil. Both are assisting very nice. Let me try. It's really difficult. It's really difficult to remove this one. Yes. કઈ પકડશે નહીં એને પકડીને કાઢવું છે કઈ બીજું પહોંચશે નહીં જીરાફે પકડશે નહીં સક્ષમ let me try 2 or 3 times, huh? Please don't bore. Really, it's difficult. See, my instrument is reaching very difficulty with there. Okay. Really, it's difficult. Sorry for I taking too much time to remove this. Let me try. Bleeding is also there. Bas. No instrument is reaching there. Because frontal sinus is very huge. Okay. So no instrument is reaching there. See that bone. Okay. I couldn't remove. This is last try. Okay. With ball point. Suction. No wash, please. No wash.
Hello.
Yes, ma'am. Achha, okay.
Hello. For the auditorium.
Yes.
I think here we have completed the removal of the septal part of the cartilaginous part of the septum, and there is a small tear over here on one side, but I think here it is normal, so it can be taken care of, and
Chaitri.
this all is
Chaitri,
done. Yes, sir.
right from the incision, I know
Yes, sir.
you have done with the septoplasty with proper correction you have got. But
Yes, sir.
for the sake of junior colleague,
Yes, sir.
Show the incision, where exactly you put the incision,
Yes, sir.
what is the name of incision, why you put there. Then after elevating
sir.
the perichondrium and periosteum flap,
Yes,
these are
sir.
the parts to be removed.
Yes, sir. So this here you can see is the mucocutaneous junction. I put an incision 2 mm behind it and elevated the mucoperichondrial flap on one side. After elevating that, I had reached to the bony cartilaginous junction and broken the junction and reached on the opposite side. After that, I had placed an incision on the cartilage, leaving the L strut intact, and elevated the mucoperichondrium on the other side, and then removed the cartilaginous part of the septum.
Chaitri, you told you kept the L strut of the septum cartilage, quadrilateral
Yes, sir.
cartilage.
Yes, sir.
So what should be the proper length and width of that quadrilateral cartilage to be kept? Approximately 2 centimeter, 2.5 centimeter, like that. Dorsally and caudally.
So superiorly, I have kept. I think I have just removed the part which was deviated. I had not gone upwards. I had just removed that was deviated part, and
Okay.
anteriorly I had kept 1 centimeter.
Okay. So minimum that much cartilage has to be kept to avoid any complication like
Depression.
nose
Yes, yes,
or
yes,
columnar
yes.
retraction.
Yes, sir. Yes, sir. Yes, sir.
Okay.
Here I'll suture this flap, and I think we'll be done then.
After suturing, would you like to put something inside both the nasal cavities?
So the splint is one option. Whenever there is a lot of tear on one side or not, we can put a splint. We generally don't do it in all the patients. We do it sometimes. And otherwise, we'll just put packing.
Okay.
Here, there's a
Then
minor tear on one side, so we'll just put the packing.
Do you keep something as a spacer to prevent synechia? Because if there is a raw area on both the side, in most of the cases,
Sir,
synechias are bound to happen.
there's only a small tear on the septum. There is no raw area on the other side.
Okay, okay. So lateral wall you have preserved very nicely.
Yes, sir. Yes, sir. Yes, sir.
Okay.
Hello, Devang sir. Hello. Hello.
Hello.
Hello, sir.
बोलिए.
Hello.
Hello.
Hi, Hitesh.
Yes, sir.
Bol.
You asked me to for the limit of the frontal recess. Okay. So see, this is the beak. Beak is always there. Okay. In case of revision, also beak is always there.
Yes.
This is the medial surface, lateral surface of middle turbinate, and this is the lamina. Okay. We have to stay in between. Okay.
Yes.
120. Section 1. Okay. Now I widen the frontal sinus with 120 degree. Now you can all see the frontal sinus. Okay.
Yes, we are within.
Very good.
Clear?
Yeah. Use round applause.
Yeah. No, sir. Yeah, this is the supraorbital recess. Okay.
Yes, sir.
Now question is, where is the anterethmoidal artery? Okay. See, this is frontal sinus. Okay. This is supraorbital recess. Okay. So
Yes.
anterethmoidal artery is immediately caudal to the supraorbital recess here. Okay.
Yes. But I think it is.
So it is the advantage of intake bulla technique. You
Yeah,
never injured the superior anterethmoidal artery. Okay.
Yes.
See the frontal sinus. Okay. Clear?
Nice. Very nice.
Any suggestions? We can show with external camera also.
No, it's okay. It is.
Later on. Okay.
Everybody is agree.
Reverse.
Nicely.
What, sir?
Frontal sinus is opened very nicely. Everybody is happy.
Okay, sir.
No
Thank
need
you.
to show the glow. We have all
Oh.
confidence on you.
Okay, thank you, sir. Thank you. Now I will use reverse cutting to clear the area just superior to the anterethmoidal artery. Okay. And anterethmoidal artery part I will keep at last. Then don't push merosil inside the frontal sinus too tightly. Okay. Otherwise it will slip laterally
Literally,
and it's
where?
difficult to remove. Okay.
At the frontal sinus. कोई confusion है?
Now this is reverse debrider blade to clear this area just superior to the anterethmoidal artery, just above the inferior anterethmoidal artery.
You are using adenoid blade?
Yes, sir. I never use this for adenoid, sir. I use for this work only, this blade.
Reverse cutting.
Yes, sir.
It's 70 degree, na? You are doing with 70 degree.
Yes, sir. Push from outside, please.
Your lamina is a little bit dehiscent.
Intact, sir. Lamina is intact, sir. Push from outside, please. See, lamina is not moving. Okay, intact. This thick mucosa I will remove. Okay.
Okay.
Let me remove this thick mucosa. See, very nice irrigation by my staff. So, very important of irrigation. See, field become clear. Okay.
Hitesh,
Yes, sir.
very good demonstration. Huh?
Thank you, sir. Thank you. Upward. Long upward, if available, please. I'm trying to remove this bone. Yes. Section.
Now anterethmoidal artery part, I will do this work. This is removal from this area at last. Okay. Now I switch over to 0 degree. After removing this bony septa, upward, long upward, please.
It is just shows
It's not reaching.
Hitesh,
Yes, sir.
frontal beak.
Frontal.
Beak.
Wait, sir. Wait. I will show you, sir. Let me remove this bone. Scoop. Wall point scoop. Okay. Okay. Wash the everything. Wash. Frontal wash. Be wash. Wait. Wash. Okay. Attach suction. Always wash all the sinuses. Okay. After open it. Make a habit of washing all the sinuses after open it. Okay. Ball point. Sir, see, this is beak. This is frontal beak. Okay, sir.
Yes.
You have to follow the beak. Okay, and you are inside the frontal sinus. This is middle turbinate. This is lamina. Okay, lamina is still intact.
The cell opened up, cell in between the lamina and frontal sinus. The cell or mucosa?
It is mucosa, sir. Thick mucosa and septa, bony septa. Upward forceps. Suction. Suction is blocked, I think. Please change the suction. झाड़ू આપી દે વાંધો નહીં એક ચેન્જ કર પહેલા તો This is the area of the supraorbital cell. Still, I have to clear it. Okay.
Yes.
Still, there is a disease in the supraorbital area. Yes. No. Upward. 60, please. Give me 60, please. Always use debrider cautiously here. Don't press the blade of debrider anywhere. Okay. Just debride it. Don't press like this. Okay. Jackson. Whenever you use debrider for juniors, don't press the debrider blade anywhere and use debrider under vision always. આ સેપ્ટા રિમૂવ કરવું છે આર્યું ને લોંગ મને ફોર્સેબલ still septa is there. See, in CT scan there are many cells. I have seen first time such type of many cells in the front of, inside the frontal sinus and frontal recess area. Yes. હવે પાછું ઈ કાઢવામાં માથાકૂટ. Debrider. Yes. Still need to clear this area. See, this is the supraorbital recess area. Still need to clear it. Sometimes debrider blade become thickened in this area. We have to take 120-degree thin blade. Okay. Still need to clear this area.
120-degree blade. Because my 60-degree blade is not reaching in these crevices. Okay. So I need 120-degree blade here. See polyp behind. In the frontal recess. Oh, sorry, in the supraorbital recess. Give me. Yes. Suction. Okay. Okay. Good. Now using 120-degree blade. Always introduce blade while suction is closed. Okay, it is very important. Otherwise, it injured the surrounding mucosa. See, my suction is off right now. Okay. While up, I reaching the target area, always on the suction. After reaching the target area, in case of debrider, okay. In anywhere, in case of while you using debrider, this is very important point for juniors. Okay. Use debrider, open the suction of debrider at the target area. Okay. Otherwise, it injured the surrounding mucosa. I am clearing the supraorbital recess. Let me show you after suction how it's look now. Still polyp are there. Okay. Still polyps are there. See in the supraorbital recess. 120. Wait. Bolu no karto. Irrigate no karto. I think suction is blocked. Kholo. Suction open kar. Suction. Don't irrigate, huh? Wait, don't irrigate. It comes in my way of endoscope. Okay, don't irrigate for a few seconds. See my 120-degree blade. I open the blade, reaching the target area, and you can use thodu. This is the supraorbital area. Okay. See the supraorbital recess. Okay, still little bit polypoidal mucosa are there. Okay. I will try to remove it.
Do you think it should be removed or it will become normal afterwards?
What, sir?
Yeah. Do you think it will?
Yes, sir. What, sir?
Do you want to
Hello?
remove the polypoidal changes from the supraorbital cell, or that will come down after surgery?
Okay. Okay, sir. You mean to say no need to remove, sir?
It's a controversial thing, so if you can
Okay,
remove
sir.
it, it's all right. That's nice.
Okay, sir. Okay, sir. Let me try once, sir. Okay. It's not polypoidal now. It's now edematous, I think.
Sedimentous thing.
Yeah, edematous, sir. You are right, sir.
Hitesh, just open up the bulla and see the frontal recess area. All this will be cleared out.
Sir, I will open it at last, sir.
Space also.
Okay. Okay, wait, sir. Sir, we will clear this area after opening the bulla, you mean to say. Okay, and now I will switch over to 0-degree. Okay.
That will be best.
Straight section, straight blade.
You can speed up your
Merosil.
surgery also.
What, sir?
You can speed up surgery in disease clearance, no? When you remove the bulla,
Yes, true, sir.
skull base in front of you, and you just manage to clear out the
Bulla.
yes.
Okay, now I am going to remove the bulla and polyp there. Okay. Now switch over to 0-degree. Okay. While doing this work, always remember, keep watch on maxillary sinus. Okay. As a landmark. Suction covered kar de. So I always clear the maxillary sinus while starting this work. Okay. Because maxillary sinus is now landmark for doing further work over the posterior ethmoid and sphenoid. Okay. So always clear the maxillary sinus before start this work. See, I am going to clear this first because always there is a blood after frontal work. Okay. So we have to keep this upper border in mind. Okay. So always clear the sinus before starting this work. Okay. It's very important for juniors. No. Straight suction, straight suction. Periosteum. Please pass periosteum. This is the bulla, okay. So I am using a periosteum elevator to remove the major chunk of the bulla, okay. Insert the periosteum parallel to the lamina. Go behind and break it inferiorly, okay. Okay. See. So we can remove major chunk.
Yes.
Debrider. Straight blade, straight blade. Straight blade, please. Okay. Wait. Let me clear this little bone. Okay. Wash. Debrider, suction. Now I clear the bulla. Okay. Polyp over the bulla. Forceps. Suction. Block. Debrider block. Take you partial block use. स्ट्रेट ब्लेड काटो बीजी काट ले फटाफट पहला बीजी ब्लेड ले ले टाइम ना बगड़े I'm trying to create a space inside, okay. So remove little bone from middle and here attachment of bulla over the middle terminal. Straight blade please. I'm waiting for blade, okay. My blade is first I clear the anterior ethmoid, okay, then I pierce the ground lamella, okay. Don't jump directly into the ground lamella, over the ground lamella, okay. So first I clear the disease in the anterior ethmoid area. Forceps. Thank you. Then clear the lamina area. Sometimes Heller cell is here, so you have to remove it also. Don't press debrider blade again and again. I telling you, all juniors, for the benefit of juniors, don't press the debrider. Okay. What happen if we breach the lamina and fat coming out? For the benefits of junior, don't pull the fat, okay. Don't pull the fat. Don't push the fat and don't pull the fat, okay. Leave it there. It will fibrose in post of 7 days, okay. So don't be panic if lamina is breached. Nothing will happen. See, this is lamina, okay. I had cleared the anterior ethmoidal area lamina, okay. Here is not danger area. What is the danger area? If you pierce the lamina of the posterior ethmoid, then there will be directly the medial rectus is there, okay. So be careful while pierce the lamina over the posterior ethmoid, okay. Because no periorbital fat, very less fat at the posterior ethmoid in the periorbita. So be careful. Point. Regular ball point, not frontal. Okay.
Now can you
Periosteum ball
check
point.
the site of the anterior ethmoid artery?
Sir, see, this is ground lamella, okay.
Yes.
This is middle terminate. This is ground lamella. Where ground lamella attach at the skull base, anterior ethmoidal artery is just above it, okay. Anterior ethmoid just caudal to the supraorbital recess and just cranial to the attachment of the lamina. Okay, so this is the anterior artery area. This is the lamina.
Okay.
Now I am going to pierce the lamina. Now I am going to pierce the lamina and enter inside the posterior ethmoid medially. Okay, inferiorly and medially. Now what is the landmark? Landmark is the maxillary sinus upper border. Okay. We have to stay inferior to the upper border to seek the sphenoid sinus. Okay. So always keep in mind the upper border of the maxilla. Okay. We have to search the sphenoid sinus here only. Okay. Make a window in the middle turbinate and expose the superior turbinate and remove it lower half. You will be directly inside the sphenoid sinus. Okay. Straight way. Always pierce the lamina inferiorly and medially.
You are working with the 0 degree, na?
Yes, 0 degree, sir.
Okay.
Block થઈ ગયા પહેલા આમ સ્ટ્રેટ બ્લોક થાય છે બીજી નવી કાઢ બીજી ફટાફટ irrigation is not working. Yes. Please correct it. હા પણ તો કર નાખ. Please make irrigation correct. Always see the maxillary sinus while working here. Okay. Always keeping the maxillary sinus in mind. See, just remove the scope, see maxillary sinus and do work again. Okay. Repeatedly see the maxillary sinus while doing this work. It's very important. Otherwise you may injure the posterior skull base. I had injured once. Okay. Merosil. I think this is sphenoid. Okay. See, air bubble is coming out. See,
Yes,
this is very important sign for juniors. Whenever air bubbles is come, sinus is open. Okay. Bleeding is there. I have to keep merosil there. Small merosil, please. In sinus surgery, bleeding is there always. So prepare yourself for bleeding. Don't do much work during bleeding. Keep merosil. Keep time to yourself and time to patient. Don't be in hurry. Okay. First identify the sphenoid ostium. Then remove the posterior ethmoidal cells. In case of Unedited situation, you not injure the optic now. Okay. So always try to identify the sphenoid ostium first. Then do the posterior ethmoidal work. Suction. Let me check because bleeding is there. No. Wait. Yes. Bleeding is there. I have to wait for few minutes also. Merosil. I have to wait for 2 minutes. You can change over to another OT also, sir.